Hey everybody, Tom Judd here. So glad to join this third symposium on clinical engineering at Sírio-Libanês and to speak today about the growing role of global clinical engineering for digital health innovations that improve low-middle income countries' workforce and safety. Wow, that's a mouthful. But clinical engineers, digital innovation, workforce and safety. First of all, let's talk about the growing role of clinical engineers. And of course, you folks know very well that clinical engineers are biomedical engineers who serve at the point of care, a WHO definition that we're calling the IFMBE Clinical Engineering Division and the Global Clinical Engineering Alliance that have been now together for several years, the global clinical engineering community, and that our key activity was a Congress last year. I'll say more about that. And this is an overview of some of the things I'll talk about. Our footprint around the world, our capacity building framework, so important. The results from our body of knowledge and body of practice survey for the community a couple years ago. And then some stories about these digital health innovations and how they're making a difference. As I just mentioned, the Global Clinical Engineering Community is IFMBE's Clinical Engineering Division, CED, and the Global Clinical Engineering Alliance. And you can see more about our Congress last year and the World Health Innovation Forum that followed it there in Vizag in Southeast India at the wonderful AMTZ MedTech Zone led by Dr. Jitendra Sharma. But a key activity last year for the community was the Congress, at which we had over 200 presenters from 110 countries involved. And you know, a significant percentage were you folks from Brazil. Now, on the right-hand side of this slide, I want to talk about something that came as a result of that World Health Innovation Forum that was right after our Congress. Dr. Sharma and his colleagues set up an Innovation Fellow opportunity, and you can see there the how folks can apply for that. This is a program that runs this year from July to December and will next year, again in 2025 and afterwards. There's room for 50 innovation fellows that follow this application criteria that you see. This year, there's over 25 in the first year out, and on short notice, that's a wonderful result. And you see 26 fellows are now at AMTZ with a 6-month program where they're working on the proposals that they submitted and that were accepted. And they're being locally there in India as well as globally mentored. And these are HTA projects, HTM, Health Technology Management, and others. And their course fees have been sponsored. They had to get a ticket there to Southeast India, to Vizag through Delhi, but once they're there. So anyway, you'll see this presentation afterwards, and you can see the link and find out more about that for the opportunity for next year. Love to see several Brazilians there. Well, the global community has this pretty incredible worldwide footprint that you see. We have over 1,100 collaborators from 210 countries, and they're all kinds of folks. Current and former ministers of health, physician and health system leaders, engineers, of course, physicists, technologists, technicians, professors, WHO folks from all over, and a growing percentage of women in leadership, and we love that. A couple of results from the past that feed what's going on with the growing role of clinical engineering is capacity building. Not every country is where they want to be. I suspect Brazil, even though it has such a robust clinical engineering program across your country and for so long, you're still building capacity where needed. So many of you seen this framework on the left before. It includes knowledge, investment, and competencies. And then the sub-buckets there, education, training, internships, credentialing, digital health and innovation, what we're talking about today. In the knowledge bucket, how well is your country, your region, your local facility investing in clinical engineering through, your devices come because you bought them, because they were donated, what kind of CE departments do you have? What kind of inventory management? How are you adding value with that investment through quality and safety measurement? And last, competencies. And I'm going to speak more about competencies a little later, but the typical competencies for clinical engineers in a wide variety of areas there. And also, how are we working with healthcare teams? How are we working through our societies? For Brazil, like A.B. Klein and others, perhaps. But how are you developing leaders, and how are you working in policy, regulation, and legislation? Now, the results of that December 2022 survey that had nearly 900 responders last year is on the right. And it's too small a data, but I want you to see that Latin America had a very robust input into that survey, and your country as well. So over 900 responses, the largest ever in our profession, with drivers. So what did we learn from that survey? And that's the next slide. We learned globally what the priorities are, and we learned for Latin America, health technology assessment, hospital engineering, maintenance of devices, and so on down the way. And by the way, on that top 10 list is what we call clinical engineering information technology, which you recognize as digital health. And once again, very significant representation of Latin America in this survey. So this really drives what CED and what IFMBE, with what GCEA are doing in our educational opportunities and our training opportunities around these priorities. Once again, you'll get this presentation after today and use it and get to all the links and all the discussion of the information. All right, so why are we talking about clinical engineers and the difference they make? Well, we had this huge response to COVID. We made our name and got great recognition during COVID because of our wonderful response around the world, and certainly there in Brazil. I remember I talked about 100 webinars here on this slide. GCA and CED were involved in. I know Brazil had dozens of webinars during those years. And certainly there's a growing global reliance on health technologies and its innovation, and part of health technologies as defined by WHO is digital health tools. And so we've written about that. You can read about it in the journal, and our profession has grown significantly. In our fourth International Congress there in Rome in 2019, 70 countries were there, but because COVID happened right after that and we had all this education going on, we grew to over 200 countries involved in our network around all these key issues that I think are important to you: capacity building, impact measurement, credentialing, and policy development. Yes, and there's an ongoing global reliance on health technologies, and check out that article in the Global Clinical Engineering Journal that speaks to that. Dr. Yadin David, of course, the president of GCEA, and myself had an opportunity to write an editorial in the National Academy of Engineering, a very prestigious group here in the US. And we said, we're growing to make a difference in healthcare, and not only in our country, but as a profession around the world. And the key ways we're doing that is through education of workforce, through developing further national health technology policy, and through our alliances and partnerships. Just to focus on one of them, and I'll come back to that, education of the workforce. The clinicians at the front lines, the doctors and nurses, are overwhelmed with not only patient demand, but also the digital health tools they're using. And so we think clinical engineers and nurses can partner together and have a curriculum where we cross-train one another so that they get freed up for direct patient care, and we can handle a lot of the technology challenges that they get to use in treating those patients. Here's a few stories. Maybe most of you are familiar with these, but our friends from Pakistan, Tazeen, who did her undergraduate in Pakistan, did her master's in UK, came back to her country because of her excellence. It's kind of like an Adriana Velazquez story. Because of her excellence at one of the key hospitals in her country, got the notice of the Ministry of Health and the World Health Organization's rep in her country. And she really helped through an oxygen survey of the country of oxygen and respiratory devices to make a difference during COVID. Feza Shaukat, also from Pakistan, getting a lot of her education, graduate education in the US, had a terrible thing happen with a relative who died early than was needed. And so Feza started an EHR company for LMICs, and it's thriving today. Other global stories of note, of course, Adriana Velazquez, who's now been at WHO for 15 years after the incredible work she did in Mexico. She was present for what had to be virtual World Health Assemblies there in 2021 and 22, I believe. In 2020, the key issue in the ministers of health was, where are the ventilators? We need you, clinical engineers. The next year, where are the oxygen sources and the delivery tools? we need you, clinical engineers. So it's increased responsibilities, and the scope that we've traditionally looked at of medical devices now also includes protective equipment for communicable disease, oxygen sources and delivery, and digital health, which is what I'm focusing on today. And another global story before I move on here is we all know about Dr. Jatendra Sharma at AMTZ there in Southeast India. On the beach. He created a medtech center to develop and manufacture medical devices in India, and he's deeply influenced national policy. And you see a note of that from the Global Clinical Engineering Journal. He had an amazing track record during COVID. I'll say a little bit more about him after a while, but he was host of our 5th Congress last year in this World Health Forum. He started this fellow program I talked about, and he's both part of GCEA and CED. Now I'm finally at the meat of my presentation. So what are the clinical engineering, health technology, digital health, global innovation stories? And I've got about 4 slides that describe these. I will not go over every detail, but here's 6 of the 12 stories I'm going to focus on. One from your neighbor, Dr. Pedro Galvan there in Asuncion, who's working with the Minister of Health for many years. His digital health innovation was AI screening for COVID patients. And you can imagine the great results from that. And then Feza mentioned already in China, and this story is in the upper right of the slide. This is a clinical engineer from China who, when come into an inpatient setting, how do you drive patients' care both with the right content and the right efficiency is with the digital health tools. Once again, you'll look at this closer when you get a copy of it. Of course, Dr. Sharma, one of the cool things he did, and they were manufacturing at AMTZ all kinds of devices and tools, thousands daily of oxygen concentrators. And so how did he get them out to the population? Well, across that large country, they had 80 warehouses. They could do service of things through there, but they could lease them, oxygen concentrators manufactured at AMTZ. They could lease them to the middle class of India in the midst of COVID. They could lease an oxygen concentrator for $5 a day and get it through Uber, through those warehouses. What a cool idea. And of course, we love our colleague who's also part of GCEA board, Dr. Dan Clark, who wanted to make sure there were accurate digital pulse oximeters for COVID, and his country first had a plan to get pulse oxes out to the population, but they didn't ensure they were accurate. So Dr. Clark and his colleagues said to the National Health Service, don't send them out unless you can make them accurate. We can help you make them accurate, and digital health tools. And, pulse oxes, how were they used in COVID? Many of you know the answer to that, but if you had one at home and you saw your oxygen saturation starting to decline, you could get healthcare quicker than waiting for it to get to a low number. If you got treated early because you saw that decline from home, you could have a better outcome if you got treatment quicker. And then a colleague doing a countrywide COVID surveillance system that was monitored through EMR and apps and labs for the Minister of Health. So what a cool set of stories. And here's the second set of them. For those of you in academia, there was a bunch of universities there in Medellin, Colombia, that got a consortium of clinical engineers and professors, developed an AI system for sepsis, and encouraging between the universities intrapreneurship and entrepreneurship, and better outcomes as a result. Our colleague in Latin America, Luis Fernandez, provided his CMMS, which is an excellent one, as freeware to his Minister of Health to monitor and track what was going on with emergency use authorization of ventilators countrywide during COVID. We all know the demand that ventilators was in countries, and that many of the countries in some ways developed their own, and they got to use them because of emergency use authorizations through the regulatory systems. Axel Worth, a colleague in the US, on the very important topic of cybersecurity management. He's spoken about it in our webinars, both CED and GCEA webinars. And so he's been training colleagues around the world, including yourselves, on adopting the best practices in cybersecurity. And you can see on the upper right of the slide a little bit about his work on public health and policy around cybersecurity, working with vendors and manufacturers, working with users and operators of equipment, and then the maintenance and infrastructure approach for to increase the value of cybersecurity. The last three here quickly, there's a digital app now through the Helium, one of our industry partners, that can, through AI, can drive telehealth access to both specialty and primary care providers within 15 minutes. You can dial into this app, you can get, as a patient, you can choose a provider for primary specialty care wherever you are in the world. You ought to find out more about that one. Then Dr. Ricardo Silva in the US, but of course we know from originally Ministry of Health, Venezuela, has been developing a digital health, a CEIT certification process, and helping spread that through LMICs and through Latin America. And then finally, Dr. Manish Kohli, physician friend who, with remote patient monitoring, is extending the ability of care to remote areas through telehealth and remote patient monitoring. So the question is, how have these 12 projects improved workforce and quality and safety? On this slide, it's a little bit busy, but bear with me. What's the clinical engineering health technology leader role? And, let's think about it for a moment. To deliver care, you need typically the clinicians, physicians, nurse practitioners, physician assistants. You need nurses, often in the other set, the primary care setting, community health workers. So what's the clinical engineering HT person doing, and other CEHT leaders and other allied health professionals? Well, we're often leading digital health innovations, or we're organizing and facilitating an innovation somebody else developed. And what impact is it having on local workforce? And I've just characterized if it's lower or medium or high, depending on how much impact on that workforce. So I've already described for you, by the way, in the upper right here, one of the 12 projects. This is Dr. Dan Clark. And what the cool thing about this is that you can see literally the clinical outcome impacts with the data provided with this particular study. So we'll make sure you can get more access to that. But having those digital pulse oximeters at home that were accurate led to reduced admissions, reduced length of stay, and supported early discharge of those COVID patients. But quickly, so our friend in Paraguay, Pedro, allowed through the Ministry of Health national screening of COVID patients and triaging of them to get more rapid care. Did that change the local workforce? Some, not too much. In Pakistan, Fez's EMR that she developed and led started to provide continuity of care. The problem, when you don't have an electronic health record around and a patient in extremis comes in to be treated, the clinicians don't have the previous information about that patient to provide ideal continuity of care and to make sure they get at that moment what they most need. And so, once again, how much has the clinical engineers changed the workforce with that? Some, but not as much as some projects. In China, Xiaomin's project made the whole care delivery process go better, quicker, faster. With digital health, you can talk to the patient before they come in through social media, right? You can treat them well when they come in and check in and make sure all their previous history is taken into account as they're treated with evidence-based care. And then when they've gotten that treatment and they leave the hospital, you can communicate with them through social media again. Once again, that has made care better. Does it affect workforce? Some. But now when you start talking about Dr. Sharma's work on meeting the oxygen needs and oxygen concentrators for particularly the paying population in India, that starts to change workforce. If patients taking care of themselves, that means there's less demand on the clinician resources, and we clinical engineers are facilitating that work. In the UK, the National and Early Warning System for those digital pulse oxes for declining oxygen sat, that started to make a difference also. Once again, the patient taking control because you've given them the right digital health tools to make a difference in their own health. And lastly, national tracking and surveilling of COVID was a good project, not a big impact on workforce, but there's more. Wait, there's more. The last projects, and I'll move through quickly once again. What are some of my abbreviations on here? If the CE and the health technology leader and other allied health develop and lead, that's a DL on my chart, or if they organize and facilitate somebody else's innovation. And we have both of those roles, you know we do, in clinical engineering. Well, in Columbia, all those universities coming together to develop that app, that was wonderful work, and it was organized and facilitated locally in Medellin, Colombia. Some impact on workforce. In Mexico, Luis Fernandez freeware, helping the Ministry of Health around tracking the ventilators and making sure the right ventilators with the right quality were getting to the right patients. Good impact. The cybersecurity, you folks knowing how to protect critical networks and keeping them in use for clinicians. A great project. When I say it's low impact on workforce, I'm just being transparent that it's 20 to 50% change. That's pretty significant, but I'm being conservative here in my discussion. But this real-time access to primary and specialty care, that's many remote places around the world can't get to see their primary care doctor or their specialty doctor. But now through digital tools, AI-driven digital tools, they can get that. In 15 minutes, can see a physician on Zoom that they've not met before, but they have a connection with, because the interaction on this app leads them to someone that they trust the first time out. That's starting to affect workforce when you can get access to a clinician you couldn't quickly before. For us clinical engineers to be understanding and using digital health tools and to be certified in that, with Dr. Ricardo Silva's work, that's a big impact on us getting work done that clinicians don't have to get done. And finally, Dr. Manish Kohli there in the upper right, I'll slow down a moment. We know there's this global shortage of health professionals, and particularly nurses, not only in the US, but around the world. And that's affecting, the demands on them are affecting burnout, all that kind of stuff. And there's so many people where there's low amount of access to physicians and so many people that have no access to physicians. So to be able to use digital health tools through that particular innovation, that we use tools developed by others, remote patient monitoring, AI-driven care, telehealth, can reduce the cost of care in remote places and give you continuity of care where not present. Just a quick story. There's this wonderful program going on in the country of Colombia where an NGO has been flying in, I think for 50 years, aircraft into remote places in that very mountainous country, and providing, bringing in clinicians and driving great care as they come in periodically. But what if you were able to take that patient population and see them all the time because of telehealth tools and because of remote patient monitoring tools, adding to the continuity of care, increasing the quality, helping them with chronic disease and so forth. That's what digital health tools and innovations that we clinical engineers working with our clinician friends can make a difference with. And finally, what are my conclusions for you today is how can clinical engineers in Brazil and within the Sírio-Libanês family contribute to these digital health innovations that improve workforce and safety, either some or a lot? And the answer is you're already doing it. I know several of you are. So you can tell your stories and you can get them published. What do those stories look like? What are the new clinical roles and workflows that clinical engineers are working with clinicians to develop? I had the privilege of working for Kaiser Permanente in the US. Many of you recognize that as a large healthcare system that's really used digital tools a lot. And I saw clinical engineers working alongside doctors and nurses developing new clinical workflows using digital health tools to deliver better patient care, and for the clinical engineers to take on new roles in partnership, particularly with those nurses, so that the nurse could have think about the patient and focus on the patient. And we clinical engineers helped make the tools easy for those nurses to use, or maybe take some of the workflow ourselves so they could provide direct patient care. So re-education of the workforce is something GCEA is working on with some of our NGO partners. For example, perhaps clinical engineers and nurses in a certain health system doing a training program and curriculum together to go out and define what's the best way for us to work with nurses to free them up for direct patient care. We talk about national health technology policy. You know, PAHO, Pan American Health Organization, the WHO Regional Office for the Americas, is doing incredible work in that area. How do you clinical engineers in Brazil get involved with that? Well, you can help address priority national challenges. And there's a PAHO document I've listed here on AI-driven care. Of course there is, because that's the big buzzword these days, and it's happening and it's making a difference. How about your involvement in the management of chronic disease? PAHO's got a document on that that's from just a couple months ago. And you can imagine PAHO's got a document on how to treat, ideally, communicable disease. And they've got a document that I've listed down there below as well. So continuing to tell your stories, continue to publish them in the Global Clinical Engineering Journal. We've got a platform for that. Dr. Saeed Khalil and many others are deeply involved with that journal, and other ones of your colleagues, and work with your national and international alliances and partnerships to share expertise and lessons learned at ABE Clin and others, your many universities. These are ways to partner together to come up with new ways to improve clinical outcomes. So we'd love for you individually and you to encourage the colleagues that you know across Latin America to join GCEA in our ongoing work. And you see that we've got a presence in nearly 10 countries and several others pending, but we'd love to have more of you involved in this work. And by the way, Pedro Moreira is the treasurer of GCEA. He's in Portugal. He's probably online with us right now. And he's a wonderful, even though he's in Portugal and you know he's Brazilian, and he's a wonderful young, strong partner of yourselves and GCEA. And so check in with Pedro, as well as Dr. Khalil, and who's speaking tomorrow and is a wonderful friend and colleague. So come along our growing presence as we work on clinical engineering, biomedical engineering, health technology, education, as we work on training, as we work on policy and certification and peer review, as well as capacity building. And by the way, you're saying, okay, we know a little bit about certification of individual practitioners. GCEA wants to help Brazil lead that, not GCEA lead that for them. But we're also developing peer review of clinical engineering departments. We're using a best practice and working with our friends from Canada who have set up a program to accredit clinical engineering departments across that country through peer review. So it's wonderful being with you here today, and thank you very much.